We obviously have to compete with Bill Clinton, which is tough, as we can see. Anyway, for those of you who are here, we very much appreciate your presence. This morning's press conference is about hepatitis. As you probably know, on 28th of July, we are going to celebrate World Hepatitis Day, and this press conference is one of the events leading up to that special day. We wanted to take advantage, obviously, of this conference, and in that context, we really are very delighted to see the increasing attention to hepatitis. There have been many events on hepatitis C specifically, in the context of this conference, much more so than in any of the previous conferences. And that there's really a very good reason that the attention is getting much stronger and much more visible. You may know that hepatitis C is a disease that affects many people in the world. We estimate there is more than 180 million people infected, and that between 130 and 150 million people are basically chronically infected, and will sooner or later require treatment. And if they don't have access to treatment, their liver will have serious damage, liver cirrhosis, in many instances liver cancer, and they will die a premature death. Just to give in comparison, to remind you, you're probably aware there's about 35 million people, estimated 35 million people living with HIV. So just to put this in perspective. And there is a great degree of overlap, a co-infection, if you wish, between HIV and hepatitis C. We estimate about up to 5 million people out of those 35 million people with HIV actually have hepatitis C. And so the challenge will be to provide treatments to them. Just to remind you, there is not only hepatitis C, there is also hepatitis B, there's also hepatitis A, and there's also hepatitis D and E. The big excitement right now, and again, very much discussed in this conference, is, however, related to hepatitis C, where some really exciting developments are taking place as we speak, with a cure just becoming now available. It is theoretically available because people yet cannot access it. And we're going to talk a little bit about this more. I would, before I introduce the other speakers, I would also recognize that this press conference has been prepared by our communication colleague, Glenn Thomas, who was tragically killed in MH17, and I would like to recognize and really have a moment of silence. Thank you. We have a distinguished panel here, and I'm going to introduce them as we go along. Andrew Ball, Dr. Ball is Senior Advisor on Strategy, Policy and Equity within the WHO Department of HIV, and the Global Hepatitis Program is also housed in the HIV Department. And he's talking about some of the recent developments and WHO's work in this context. Andrew, please.
Okay, thanks very much, Gottfried. As Gottfried has already mentioned, there has been increasing interest in hepatitis over the past couple of years. It's come very late, but we have seen that there has been very significant movement just recently. A lot of that has been initiated through civil society. So it has been civil society really pushing for the World Health Organization and others to take action on what really is a major public health issue affecting all regions. In follow-up to a lot of the actions by civil society, there has also been a huge amount of momentum from individual countries. And we have seen that that interest in a broad range of countries actually resulted in a major debate being held at the World Health Assembly in May this year. And in those discussions, all 194 countries represented at the World Health Assembly endorsed a resolution for very comprehensive action both at a global level and also in countries to address hepatitis. And some of the very interesting new developments in that resolution is a very strong call for supporting scale-up of treatment, which includes initiatives to improve access to affordable and quality medicines. There is also a call for work to be undertaken to actually look at the actual economic impact of hepatitis globally and in different communities, and what the feasibility is of actually eliminating hepatitis in the coming years. So we're actually looking at a possibility of developing a plan in the coming year with a possible goal of eliminating hepatitis sometime in the future. Just in association with this new resolution, we recognise that that there has been this call to action from countries, but clearly much of the work has to be undertaken by a broad range of stakeholders and partners. And to make you aware, to actually start mobilising that network, that broader base for a very significant hepatitis response, we have had a number of meetings earlier in the year, in April, in which we brought together a broad range of partners, including civil society, donors, program implementers, and other stakeholders, academics that are very much critical players in the hepatitis response. Through that partnership, through that building that network, we will be looking at developing a global strategy that can actually address hepatitis, so that we can develop a similar level of momentum as we have seen with the HIV movement, for example. Thank you.
Thank you, Andrew. So really, it's the moment for moving from rhetoric to action. A global strategy and global plan is needed, and WHO will convene partners to take this forward. Philippa Easterbrook is a scientist working in the also in the WHO's HIV department, and has been taking the lead in developing some of the recent guidelines that were launched by WHO just earlier this year. Philippa, please.
Thank you. Well, a very important early part of the WHO response is the development of management guidelines for hepatitis B and C. And although guidelines for these conditions exist in high-income countries, until recently there was nothing for low and middle-income countries, despite their very high burden of disease. And this is also partly because the treatments that were available, particularly for hepatitis C, were costly, difficult to administer, difficult to monitor, and not well tolerated. The big change is now with the development and approval of a completely new class of oral drugs, the DAAs, the direct-acting antivirals, which can not just treat the virus, but offers the potential for cure in a large majority of patients with just 12 to 24 weeks of treatment that are easy to take, simple to take, and well tolerated, and most importantly, offer the potential to be more widely available and at lower cost in the low and middle income countries that need them most. So in April this year, we launched management guidelines for hepatitis C at the European Liver Society meeting, and this includes recommendations, and there's some copies in the front here, from screening to assessment of stage of liver disease to preventative strategies, as well as the various treatments. And this has now been followed up with treatment guidelines for hepatitis B, which will be available at the end of the year, and importantly includes a recommendation for the use of a drug that is widely available at low cost in a generic form, that's tenofovir, for the treatment of HIV in many parts of the world. I think the guidelines are obviously just one first step. And it is very important for WHO to promote and support countries as they adapt these guidelines to their own particular situation. And that is a high priority for us to work with countries and civil society to help translate this into action. I think one other final point is and a challenge to treatment scale-up is and barrier to treatment is the lack of access to low-cost and simple diagnostic tests. And also the lack of guidance on who to screen and how to screen and when to screen. And at present, the diagnosis of hepatitis B and C and deciding who to treat is based on a two-step process. So an antigen test for hepatitis B, an antibody test for hepatitis C, and then the need for an additional costly test and complex test to determine how much virus there is in the blood and who needs to be treated. So I think this is a priority moving forward, and WHO is helping through its pre-qualification program to identify what are the best tests to use and to also ensure that the tests are reliable, the ones that are available in country. Thank you.
So that is exactly why we all believe it's such a decisive and important moment. The pieces are starting to fall into place. Drugs that can cure are available, are out there, are available yet not out there. Guidelines how to deliver those and use those have been put in place, and really the momentum is building up. However, the services are not provided yet, and Margaret, can you share some thoughts about how would you think about delivering those services? Margaret Hellett is head of the Centre for Population Health at the Burnet Institute, Monash University in Melbourne, Australia. Margaret, please.
Thank you, and good morning. I think it's pretty simple. We're at a moment in time. These new drugs are available and hepatitis C is curable. The people who need to be treated, predominantly in the world, are people who inject drugs. There are exceptions in other countries, but in many places it's people who inject drugs. A key issue is that we do not provide care to these people properly. This can be done. People who inject drugs are open to care. They are not a difficult population to manage. I have many, many years of experience of treating people who inject drugs for hepatitis C. When I first started to do it, people said, surely you don't treat active injectors, they're unreliable, this, that and the other. It's simply not true. There is stigma, there is discrimination, and in many, many places in the world, real problems with the law that make it that people who inject drugs cannot access health services. It's not that they don't want to, it's what we do in how we present them, both due society constructs and as well in places like Australia where we have a reasonably open health service system, we don't provide those services in the right places. The models tell us that if we treat people who inject drugs, active injectors, with these new medications, we can eliminate hepatitis C. They need to be combined with harm reduction programs, needle and syringe programs and opiate substitution therapy. Many places in the world don't have these. But if we provide these health services in places where people who inject drugs are, in community-based settings, it will be entirely possible to eliminate hepatitis C. In Melbourne, we have primary healthcare settings where myself and colleagues, as well as doing treatment in the big clinics, I'm an infectious diseases physician and work at the Alfred Hospital, but as well in doing the clinics there, if you take those clinics to the communities, you can treat people who inject drugs easily. They like to go there. It's a one-stop shop. They can get their needle and syringes, they can get their opiate substitution, they can get advice on housing, they can get counselling, they can get a shower, they can get clean clothes and shoes. This is not difficult. The difficulty is that we don't choose to implement it. So this is a real possibility. We have a moment where we have cure, combined with quality harm reduction, we can do an enormous amount over the next 10 to 15 years.
Thank you very much, Margaret. Sofosbuvir is the first drug that has been licensed in the United States. As you probably have heard, the price is $84,000 for a 3-month course. That means 12 weeks, 1 tablet a day. That means 1 tablet costs about $1,000, a little less than $1,000. Tracy, what can be done to bring the prices down? What can be done to actually make this a reality for the people that need and are waiting out there and that would otherwise die if they don't get that access? Tracy Swan is the Hepatitis HIV Project Director of the Treatment Action Group in the United States.
It's wonderful to have treatment guidelines, and it's wonderful to think about how to start curing people who are in desperate need. But these drug prices are completely unacceptable, and I think of us as not so civil society anymore. The benchmark of a US-based price, $1,000 per day, if companies offer a discount, this is not the proper benchmark. The real benchmark should be how much it costs to produce the drugs, along with a package of diagnostics, monitoring, and care. And there was a wonderful poster here by Andrew Hill and colleagues that says you can generically produce, with profit and sustainability, a treatment course for people with hepatitis C, regardless of their HIV status, their liver disease status, et cetera, for less than $300 a year. So I think it's time to look at patent barriers, IP, and what the real pricing benchmark should be based on. Even the classic cost effectiveness data supports unsustainable and unacceptable and extortionate pricing. And if anyone wants more information, I have some of these reports. I'm happy to distribute them. And as Oscar Wilde says, I have the simplest taste. I'm satisfied with the best. That's what people with hepatitis B and hepatitis C deserve.
Thank you very much, Tracy. Obviously, a lot of the action has to happen in countries, and some countries are starting to really take this very seriously and start playing a leadership role. Brazil is one of those. Dr. Fabio Mesquita is the National Director of the HIV, Hepatitis and STI program. Dr. Mesquita in Brazil. Dr. Mesquita, what are the next steps that are being thought of or taken in Brazil at this point?
So thanks, Gottfried. Good morning, everybody. I think it's a very interesting momentum. So Brazil is a middle-income country. We have been working with hepatitis in the last 12 years, and the country offers free universal access to treatment since then for hepatitis B and hepatitis C. And of course, as much as we have all those developments, we see new windows of opportunities to improve our response and to get to the best solution for the patients, which is our main goal. So Brazil was the sponsor of the 2 resolutions on hepatitis in the World Health Assembly. The one in 2010, who helped to create the global program on hepatitis and to create the International Hepatitis Day, the World Hepatitis Day, which is 28th of July. And also the resolution of 2014 that was mentioned by Gottfried and Andrew as a very important resolution to guarantee next steps forward, universal access to prevention in the case of hepatitis B with vaccines, and universal access to treatment for hepatitis B and C. Also, we see this merge in the Department of HIV in WHO that we did in Brazil a few years ago, that we merged the hepatitis and HIV departments. It's a very important step forward because, let's think about the treatment of hepatitis B, most of the countries are already using tenofovir to treat HIV, and we can use exactly the same drug to treat hepatitis B. And there's no reason why we can treat a person living with HIV and ignore a person living with hepatitis C alone. The same for hepatitis C, where the experience and the services organized in countries are very well structured for HIV, and therefore we can do this step forward of also include people that has hepatitis C alone, even without co-infection. I think the guidelines, it's a great achievement from WHO, very important for us, and they're also helping us to build the new Brazilian guidelines with the goal of having in the near future interferon-free treatment in our country. We also consider a very key element of this momentum, the intense participation of civil society, as Trace just mentioned, and the intense participation of the scientific community, as Margaret mentioned, from the cooperation of Burnet Institute and some others. So I think these joint efforts of international organizations, civil society, scientific community creates this fantastic momentum that we need to get from. Again, we have cure for hepatitis C, which is different from HIV, where we keep, or hepatitis B, where we keep people for long life treatment, but for hepatitis C, we have cure in few weeks of treatment with these new drugs and new developments, which is a terrific achievement of the scientific community. But as Trace said, we need to really fight for get better prices. And Brazil is really committed, as it was in the fight to HIV, to the provision of universal access of treatment of HIV in the past, and the role that the country played on that. We are really committed to play the same role to push for universal access of free hepatitis C treatment in an affordable price and a reasonable price that can really guarantee that everybody who needs God's treatment. I think it's a perfect momentum. No one should be left behind, and including in principally people who inject drugs, which is a very key element of the spread of hepatitis C over the world. So thank you.
Thank you, Fabio. In many ways, we are at a moment now with hepatitis C where we were with HIV in 1997. Drugs became available, they were very expensive, and they were reserved to the very few that were privileged and able to access them. It took us 15 and more years to get where we are in HIV, and still we haven't been able to assure universal access. I think we have the opportunity for hepatitis because it is a cure, because it is a very simple 3 months treatment course, to learn from the HIV movement, but to do it faster, to do it more effectively and efficiently. It will obviously require affordability of those drugs and the services and the health system to deliver them. You are probably aware there are also campaign materials. If you wanna look into the WHO website, you can access the hepatitis campaign materials, and the slogan of this year's World Hepatitis Day is "Think Hepatitis." Even though we all here talk a lot about it, the general public out there is often still very unaware of hepatitis. Many people are not tested, and many people who are actually possibly chronically infected with hepatitis do not know until symptoms appear. So the idea really is to reinforce awareness around hepatitis and to make people think about hepatitis. Thank you. If there's any questions, please raise them now.
Hello?
We hear you. Kindly identify yourself.
while I absolutely agree with what Tracy said about prices, I suppose the likely outcome will still be that in the high-income countries, this will remain a very costly treatment for the years to come. How much do we need reinforcement and renewed efforts to prevent hepatitis C infections among key populations, particularly among, for example, intravenous drug users and MSM? Because if they need that treatment repeatedly because they reinfect, that may cause very difficult discussions in the healthcare systems, and the experience so far was that while harm reduction programs have reduced HIV among intravenous drug users, the effect on hepatitis C was much lower. So there are, with the current harm reduction programs, we address a large proportion of modes of transmission which are still there. And for the sexual transmission among MSM, we don't have clear messages on how to prevent that.
So thank you for the question. Do you want me to? I'll have a go at addressing some of that. So my first thing is, I do think the treatment will become cheaper even in developed countries. I think as the different drugs come online, it will become cheaper. Maybe not cheap as we would like it to be, but it'll become cheaper. So that's the first thing. Second, I don't think we should be thinking about hepatitis C treatment on its own as a treatment as prevention. It is vitally important that we continue to scale up harm reduction programs. Needle and syringe programs do work to reduce hepatitis C transmission. The reality, in Australia, we can see the return on investment, they're highly cost effective. What we don't have in many places, including Australia, is full coverage to make sure that everybody who injects has access to a clean needle and syringe all of the time, 24 hours a day. Similarly with opiate substitution therapy, invariably we do not have what we will call full coverage for people who are using opiates. And so there is some papers coming out soon that clearly show that quality opiate substitution therapy reduces the incidence of hepatitis C. But you will find in many places we do not have rollout as we should, and we really need to continue to push for that to occur. These things need to be done in combination. In terms of reinfection, the evidence so far in terms of people who have been treated for hepatitis C is the likelihood of reinfection is actually quite low. It might be to do with moments of time, it might be to do with the previous complexity of treatment, we don't know. But as a person that follows both cohorts of people who inject, yes, we see reinfection, but following treatment we see actually very low levels of reinfection. In men who have sex with men, it is a little higher, and we do need to make sure those messages are really clear, because I think it's something that's not well understood, that hepatitis C reinfection occurs. So this is where you need the communities to be well educated and people to be well educated. So it's not just that treatment's going to do the job, a comprehensive approach.
Thanks, Margaret. Tracy?
There has been some research into the epidemics of hepatitis C among men who have sex with men, especially HIV-positive men. But I think the modes of transmission, the risk, the biological, cultural, and behavioral factors aren't entirely clear. Nonetheless, there's been a huge failure to get any messages out to people from their communities into their communities. You're absolutely right. And I think information, prevention, harm reduction, all of this is part of a complete package of care and treatments that's linked to human rights and should not be linked to how much it costs to provide treatment. Thank you for your question.
Andrew?
Okay, just a comment. Hepatitis C is much easier to transmit than HIV, and so we do need to rethink the harm reduction programs. particularly looking much greater focus on injecting paraphernalia. So it's not just about needles and syringes, it's looking at the much broader range of paraphernalia that are being used. So we do need to rethink that and look at repackaging. We also need to recognise that in other parts of the world, in different countries, that most transmission isn't occurring among contaminated blood through reuse of contaminated needles and syringes and surgical equipment. And this is particularly the case in the country with the highest prevalence, Egypt, and in countries such as Pakistan. So we are also getting on board our blood safety, injection safety programs to actually intensify their efforts, and very shortly there will be the release of a new, or the launch of a new initiative on injection safety by the World Health Organization.
Thank you. Are there any other questions? Yes, please. Yes, maybe you step over and use the mic, please.
Thanks for your presentations. I'm keen to hear more about hepatitis C and HIV co-infection. Specifically, do people who have both respond more poorly to existing hepatitis C treatments? And why is that the case?
People with HIV, in terms of the new medications that are coming out, are showing that their response is just as good. So in terms of the new direct-acting antiviral agents, the response rates are again fabulous, and so I think we will have no issues there. The response in the current treatments is a little lower, but it's still very good, and you should not treat somebody for their hepatitis C just because they're HIV infected. It should never be thought of in that way.
And what about the old style treatment?
So the existing is, I mean, it depends. If somebody's infected early, so if somebody who's HIV positive, if you can detect their hepatitis C early, studies which are actually being done in Australia clearly show that treatment responses are excellent. It falls a little compared to people who are not co-infected with more chronic disease, but still response rates are well and truly good enough that you would treat somebody.
One additional element I just want to mention is disease progression in co-infected individuals is much faster. In other words, liver damage, liver cirrhosis, etc., seems to appear much quicker than in mono-infected individuals.
And also in some of the studies of the new direct-acting antivirals, the cure rates have been higher among people who are HIV positive, and a lot of people suspect that this is due to the years of education, information, and support around adherence to medication. So people really understand not just you have to take this medicine at this time, but why it works, how it works. And that message, I think, really, we're going to need a lot of peer educators, community healthcare workers, et cetera, to really get that message out for hepatitis C monoinfection as well.
Okay, thank you.
Thank you very much. Any other questions? If not, the speakers are available for a more in-depth discussion now or anytime later. Gunda Weiler, who is over here, please identify yourself. If you have, over the course of the week, any additional information needs or want to talk to any of us, kindly approach him, and we certainly would be more than happy to arrange further conversations. Thank you very much.